Hi, my name is Dan Klein. I'm from the Department of Psychology at Stony Brook University, and I'm delighted to be participating in the SSCP Virtual Clinical Lunch Series. I'm going to be talking about multifinality, transdiagnostic factors, equifinality, and heterogeneity. I'll be applying these concepts, to the examples of irritability and depression in youth. Takes a second to advance these slides. I'm sorry. Once it gets going, it works. There we go. So funding for the work I'm going to present today comes from the National Institute of Mental Health, and there are no disclosures to present. There are a number of people who've played critical roles in the work that I'm going to present today, and some of my key collaborators are moving from in a clockwise fashion. Dr. Gabrielle Carlson from Stony Brook, Dr. Leah Dougherty from the University of Maryland, several former and current graduate students, Ellen Kessel, Jamila Silver, and Harriet DeGroot, and my colleague, Dr. Roman Kotov at Stony Brook. So the first part of the talk is going to focus on multifinality and transdiagnostic factors. As many of you know, multifinality refers to a risk factor that influences multiple developmental outcomes. And when the outcomes are forms of psychopathology, the risk factor can be referred to as transdiagnostic. Irritability is often defined, and I'm going to be applying these to irritability. Irritability is often defined as a low threshold for experiencing anger in response to frustration. And it can manifest as a persistently angry or grouchy mood and/or as temper outbursts. And irritability is one of the most common reasons for referring children and adolescents for mental health services. Irritability has recently emerged as a major research focus, thanks in large part to the work of a handful of pioneering investigators, including Ellen Liebenloft, Argyris Stringaris, and Lauren Wachschlag. So recent interest in irritability is the product of several historical developments and lines of research. One is that emotion dysregulation, particularly irritability, is a very common manifestation or symptom in attention deficit hyperactivity disorder. However, in order to maximize diagnostic specificity, the Diagnostic and Statistical Manual of Mental Disorders, DSM, has not included irritability in the criteria for ADHD in any of its editions. I think that's left a bit of a gap where it's unclear about how to note this feature. A second contributor is the literature on some of the literature on oppositional defiant disorder, ODD, which has shown that ODD can be parsed into several dimensions, reflecting first angry and irritable mood, and secondly, argumentative and defiant behavior, and in some studies, a third factor reflecting vindictiveness. And each of these dimensions has different prognostic implications. Then finally, probably the most important contributor to the interest in irritability and the growth of that literature has been the fact that DSM-4 inadvertently de-emphasized the episodic nature of mania. And that led to an unintended epidemic of pediatric bipolar disorder, or at least an epidemic of pediatric bipolar diagnoses in the 1990s and 2000s. So children who were explosive and hyperactive, but who did not have distinct episodes of elated mood, were suddenly being diagnosed as having bipolar disorder. And that was a problem because many of these children were being treated with medications that had significant side effects and were probably not very helpful. So in response, the DSM-5 created a new diagnostic category, disruptive mood dysregulation disorder, or DMDD, not because there was a lot of evidence favoring it, but it was a decision that was made in order to provide an alternative diagnostic home for dysregulated, explosive children with both temper outbursts and persistent irritable mood. So irritability is arguably the most transdiagnostic symptom in the DSM-5. It, or a closely related term, is a criterion for major depressive disorder in youth, for manic and hypomanic episodes, for disruptive mood dysregulation disorder, for generalized anxiety disorder, post-traumatic stress disorder, oppositional defiant disorder, intermittent explosive disorder, borderline personality disorder, and antisocial personality disorder, among others. Irritability is also a quintessential example of multifinality, as it predicts a wide range of psychopathology and functioning outcomes. So in the Great Smoky Mountain study, which is arguably the best epidemiological study of childhood psychopathology, that study, irritability in childhood predicted increased depression, anxiety, aggression, and risky and illegal behaviors in young adulthood. So a wide range of outcomes. In our own work in the Stony Brook Temperament study, which is an 18-year follow-up of a community sample of 3-year-olds, we found similar kinds of things. So when the children were at age 3 and 6, they received their parents received a semi-structured diagnostic interview, the preschool age psychiatric assessment, or PAPA. And then in subsequent waves at ages 9, 12, 15, 18, and currently 21, the youth has been interviewed with a semi-structured interview, the Kitty schedule for the affective disorders and schizophrenia, or the KSADS. And through age 15, a parent was also interviewed as well. And so I'm going to present very briefly what some of the outcomes we've been finding for irritability in 3-year-olds, so in preschoolers. And these data come from a paper that was recently published by Leah Sorcher and Leah Doherty and other members of our group in the Journal of the American Academy of Child and Adolescent Psychiatry. And we found that irritability at age 3 predicted anxiety disorders in adolescence, including specific phobia, social anxiety disorder, and generalized anxiety disorder. It also predicted increased rates of attention deficit hyperactivity disorder, ADHD, and increased rates of disruptive behavior disorders. It also predicted, and this was after including a number of covariates in the model, it also included depressive symptoms, according to mother and father report, although not child self-report, on the Children's Depression Inventory. It predicted irritability at age 3, predicted increased anxiety symptoms at age 15. Again, according to mother and father report, not so much youth report on the screen for anxiety-related disorders. Irritability at age 3 predicted poorer peer functioning and poorer global functioning at age 15. It predicted greater non-suicidal self-injury, more educational and mental health service utilization, and greater use of antidepressant medication. So a wide range of outcomes. So what might account for this multifinality? Why would the same risk factor lead to so many different outcomes? Well, there are a number of possibilities, but 2 of them are, first, that there are other factors that moderate its effects. We can refer to these as pathoplastic moderators, because the moderation is influencing the expression, the pathoplastic expression of the phenotype. Or the risk factor may be heterogeneous or multidimensional, with different aspects predicting different outcomes. And I'm going to consider both of these scenarios right now. So we'll start off by talking about pathoplasticity. So pathoplastic moderators. So why do some irritable children develop more internalizing outcomes and others exhibit more externalizing outcomes? What are the pathoplasticity factors that might moderate these divergent phenotypic pathways? Well, Ellen Kessel and I came up with a couple of criteria for potential moderators to examine. And the first criterion is that the potential moderator should have opposing effects on internalizing and externalizing psychopathology. And secondly, it should not be correlated with irritability. And looking in the literature, there seem to be 2 candidates that met these criteria. The first is error processing, and in particular, the ERP component error-related negativity, which I'll talk about in a second. And the second is salivary basal cortisol. And the error-related negativity and salivary cortisol are products of different biological systems, but in a general sense, both reflect activation of self-regulatory systems that respond to threat. So event-related potentials are measured measure cortical electrical activity on the scalp using EEG. And an event-related potential, or ERP, is the average response evoked by a stimulus over many trials. And one such ERP component is the error-related negativity, or the ERN. The ERN appears as a negative deflection at frontocentral electrodes approximately 50 milliseconds after the commission of an error. And it appears to be generated in the anterior cingulate cortex, which is an area where information about threat, punishment, and pain is integrated to modify behavioral output. The ERN has a number of psychopathology and personality correlates. The ERN is enhanced in many internalizing disorders and traits. For example, generalized anxiety disorder and obsessive compulsive disorder in adults. It's increased in anxiety disorders of all kinds in children and adolescents. And it's associated with greater temperamental fearfulness in children and with higher levels of worry, anxious apprehension, checking, punishment sensitivity, and intolerance of uncertainty in adults. On the other hand, the ERN is attenuated in many externalizing disorders and traits. So, for example, there are lower than normative ERNs associated with antisocial behavior, substance use disorders, and impulsivity in adults, and attention deficit hyperactivity disorder, disruptive behavior problems, and juvenile offending in youth. So to examine this, we used several waves from the Stony Brook temperament study. When children were 3 years old and first entered the study, we assessed irritability as part of the longer semi-structured diagnostic interview, the PAPA, which was conducted with a parent. And parents also completed the child behavior checklist, from which we extracted the internalizing and externalizing symptom scales. At age 6, children completed a go, no-go task. And in this task, their job was to press a mouse button whenever they saw an upward pointing green arrow. And if they saw an arrow that was in any other orientation, pointing down or pointing a little bit off to the left or to the right, they were not supposed to press the mouse button. So the go stimulus was the upward pointing green arrow, and everything else was a no-go stimulus. And we scored the ERN at 100 milliseconds after their response. And in our sample, as we had thought, irritability and the ERN were not correlated. Then at age 9, we assessed symptoms again using the CBCL. This is what we found. So we conducted 2 regression models, one for internalizing symptoms, the other for externalizing symptoms. And in the first model, we regressed internalizing symptoms at age 9, on age 3 irritability, age 6 error-related negativity, ERN, and on the interaction between irritability and the ERN. And we adjusted for a number of variables, including internalizing and externalizing symptoms at baseline and externalizing symptoms at outcome at age 9. And we found a significant irritability by ERN interaction. You can see over on the right what that interaction looked like. And what we see is that for children with enhanced ERN, we see that irritability symptoms are significantly associated with irritability symptoms at age 3 are significantly associated with internalizing symptomatology at age 9. On the other hand, for children with a blunted ERN, there is no relationship between irritability and internalizing symptoms. The model for externalizing symptoms, same thing, we regressed age 9 externalizing symptoms, on age 3 irritability, age 6 ERN, the interaction, we adjusted for concurrent internalizing, externalizing at baseline, and for internalizing symptoms at outcome. And we again found a significant irritability by ERN interaction. But as you can see, it takes the opposite form. Here we're seeing that children with a blunted ERN for children with a blunted ERN, irritability symptoms at age 3 predict externalizing symptoms at age 9. Whereas for children with an enhanced ERN, there's no relationship between irritability and later externalizing symptoms. So to summarize, for children with an increased ERN, irritability predicted relatively more internalizing symptoms, whereas for children with a blunted ERN, irritability predicted relatively more externalizing symptoms. So ERN seems to be a pathoplastic moderator that influences whether irritability is going to predict relatively more internalizing versus relatively more externalizing symptoms. What about cortisol? So cortisol has a diurnal slope with the highest levels in the morning and the lowest levels in the evening. Internalizing psychopathology, particularly depression, tends to be associated with higher morning cortisol levels. On the other hand, externalizing psychopathology has been consistently associated with a blunted diurnal slope. So there's low cortisol throughout the day, including in the evening. So again, at age 3, we assessed irritability using the PAPA and internalizing and externalizing symptoms using the CBCL. At age 9, we assessed children's salivary cortisol, and we measured cortisol at waking and at bedtime for 3 consecutive weekdays. And we modeled the cortisol slope as the latent difference score between the PM and the AM values. And irritability and the cortisol slope were not correlated. And at age 12, we assessed internalizing and externalizing symptoms again using the CBCL. And we conducted a similar set of models as we did for the ERN. So we regressed CBCL internalizing at age 12, on age 3 irritability, age 9 cortisol slope and their interaction, and we adjusted for internalizing and externalizing symptoms at baseline and externalizing symptoms at age 12. We found a significant irritability by cortisol interaction. What we see is that for children with a steeper, cortisol slope, there's a significant relationship between irritability symptoms at age 3 and internalizing symptoms at age 12. On the other hand, for children with a more blunted slope, there's no relationship between irritability symptoms and later internalizing symptoms. Looks like there might be here, but it's not at all significant. Then in the second model, we did the same thing, looking at externalizing symptoms at age 12, regressing that on irritability at age 3, cortisol slope at age 9, and the irritability by cortisol slope interaction. And we again found a significant irritability by cortisol slope interaction. And here we see sort of the mirror image of what we just saw before. Here it's children with a blunted cortisol slope who are showing a significant relationship between early irritability and later externalizing symptoms. Whereas for children with a steeper cortisol slope, there's no relationship between early irritability and later externalizing symptoms. So to summarize, for children with a steeper cortisol slope, irritability predicted relatively more internalizing symptoms. For children with a flatter cortisol slope, irritability predicted relatively more externalizing symptoms. All right, so some evidence for pathoplastic moderators. Let's move on and talk about components of irritability and how they may help explain multifinality. So Ellen Liebenloft, who's been a pioneer in this field, as I mentioned, has distinguished between tonic and phasic irritability. Tonic irritability refers to touchy, grouchy, easily annoyed mood, and phasic irritability refers to temper outbursts. Similarly, my colleague, Gay Carlson, has distinguished between how one feels, that is irritable mood, and what one does, temper outbursts and rages. So this is a distinction that people have talked about recently, and so we applied it in a different study, the Adolescent Development of Emotions and Personality Traits, or a DEPT study, which Roman Kotov and I have been conducting for some time. And this is a longitudinal study of a community sample of about 550 early adolescent girls. They were about 14 and a half when they entered the study. And we conducted 5 assessment waves at 9-month intervals, so 5 waves over the next 3 years. And then a 6th wave was conducted 6 years after baseline. And I won't be talking about that sixth wave now, but I will talk about it a little bit later on in the talk. So at wave one, participants completed a number of scales, some of which included subscales tapping anger, such the International Personality Item Pool, or IPIP, the Bus Perry Aggression Questionnaire, and the Temperament and Affectivity Inventory. And there were 28 items in this battery that seemed to index irritability or something like irritability. And so that's what we started with, those 28 items. At the initial wave and at 18 and 36 months, participants were interviewed with the KSATs. And then at 36 months, or 3 years later, after the entry into the study, participants also completed measures of relational aggression and risky sexual behavior. And we're including those because this is a sample of girls, and so rates of externalizing disorders are a bit lower than they would be in boys, but externalizing behavior in girls can sometimes take a different form than it does in boys, and that often includes relational aggression, and it might include risky sexual behavior. Not to say that boys don't engage in those behaviors as well, but they may be in some ways more characteristic of an externalizing trait in girls. So we took those 28 items and we did an exploratory factor analysis. And parallel analysis indicated that there were 4 factors in the data. There were 24 items out of the 28 that had unique loadings greater than 0.4 on just a single factor with no cross loadings. So 10 items spanning the 3 scales had unique loadings on the first factor. And these items described a persistently angry, irritable, grumpy mood and appeared to reflect tonic irritability. Factor 2 had 3 reverse-coded items reflecting an even-tempered disposition. Factor 3 consisted of 7 items, also spanning the 3 scales, which tapped surges of intense anger and appeared to reflect phasic irritability. And then factor 4 had 4 items reflecting moodiness in general rather than irritability specifically. So it appeared to us that we had a fairly clear tonic irritability factor and a fairly clear phasic irritability factor, factors 1 and 3, and that's what we focused on. And those 2 factors were moderately to highly correlated, which is not surprising. So then we looked at the outcomes 3 years later, the diagnostic outcomes associated with tonic and phasic irritability. And in each case, we ran regressions where we adjusted for the baseline diagnosis and for the other form of irritability. So if we look at the second column here, we see that tonic irritability adjusting for phasic irritability. Tonic irritability uniquely predicted depressive disorders and generalized anxiety disorder. We look at the next column, phasic irritability uniquely predicted a lack of lower rates of generalized anxiety and higher rates of oppositional defiant disorder, conduct disorder, and alcohol and drug use disorders. So tonic irritability is a unique relationship with later internalizing psychopathology, and phasic irritability has a unique relationship with later externalizing psychopathology. And this is also borne out when we look at risky sexual behavior and relational aggression, which in both cases are independently associated with phasic irritability, but not with tonic irritability. So this was a sample of adolescents. The next question was, can tonic and phasic irritability be differentiated in younger children? And do they again have different correlates and outcomes? So turning now back to the Stony Brook temperament study, which, as I've mentioned, is a community sample of 3-year-olds who've been followed every 3 years through adolescence and actually now at age 21. And so we looked at the age 6 wave, in which we had 452 parents and children participating. Parents completed the PAPA, as I've mentioned before, and a number of questionnaires about child temperament and parenting and psychopathology. And parents and children participated in a battery of interaction tasks. And the youth and a parent were interviewed using a semi-structured diagnostic interview, the KSATs, at ages 9, 12, and 15. So we did a confirmatory factor analysis of a number of items that seemed to tap irritability, which we pulled from the PAPA from the CBCL, from Mary Rothbard's Child Behavior Questionnaire, and Ken Gato's Child Symptom Inventory. And we posited a 2-factor tonic and phasic model with 7 tonic items and 4 phasic items. Model fit was excellent. All items loaded significantly on their designated factor. And the 2-factor model fits significantly better than a 1-factor model. And again, the latent tonic and phasic factors were highly correlated. So despite the high correlation, we want to know if they have unique effects. So first we looked at concurrent associations with temperament and parenting, with each form of irritability adjusting for the other. So adjusting for phasic irritability, we see that tonic irritability predicted negative affectivity, but none of the other temperament and none of the parenting dimensions. Phasic irritability, adjusting for tonic irritability, also independently it was associated with negative affectivity, but it was also uniquely associated with higher levels of surgency and lower levels of effortful control. So tonic irritability is related to a temperamental negative affectivity. Phasic irritability is also related to temperamental negative affectivity, but these children also tend to be very surgent, have a lot of energy, they're very active, and they suffer from diminished self-control or effortful control. We look at parenting. As I said, tonic irritability was not related to parenting, either observed or self-reported by the parents, whereas phasic irritability was related to every one of the parenting measures in this table. So phasic irritability was associated with lower levels of observed parental support, higher levels of observed parental hostility and intrusiveness, and higher levels of parent-reported authoritarian and permissive parenting styles. So these are concurrent associations. What about predicting psychopathology in adolescence? Age 6, irritability predicting psychopathology in adolescence. Here we see that tonic irritability, adjusting for phasic irritability, significantly predicted an increased rate of depressive disorders, of social anxiety disorder, and of specific phobia, and also increased suicidal ideation, suicidal behavior, and non-suicidal self-injury. On the other hand, phasic irritability, adjusting for tonic irritability, predicted increased rates of ADHD and disruptive behavior disorders. So again, we're seeing unique relationships between tonic irritability and internalizing psychopathology outcomes, and phasic irritability with externalizing psychopathology outcomes. One last study on tonic phasic, and this is this sort of extends our work into a clinical sample. The ADEPT study and the Sternberg temperament study both use community samples where levels of irritability and psychopathology are much lower. What about a clinical sample? So we've recently done another study using a large clinical sample of almost 2,500 youth taken from the Stony Brook University Child and Adolescent Psychiatry Outpatient Clinic. And we used parent and teacher, and so far we've been talking about youth and parent report. We extended here to teacher report as well as parent report. And the parents and teachers filled out a battery of questionnaires, and we selected 15 irritability items from the various parent questionnaires and 10 from the various teacher rating scales. We conducted analyses separately for parent and teacher ratings. Both parent and teacher, and we did confirmatory factor analyses on the irritability items for both parents and teachers, and each yielded, in each case, we posited a tonic and phasic dimension, and model fits for each of these models was good. Again, the tonic and phasic factors were moderately to highly correlated, and both of the models had a significantly better fit than a single factor model. We also found that there was scalar measurement invariance between parents and teachers in their ratings, meaning that parents and teachers were basically interpreting the tonic and phasic irritability items in the same fashion. But at the same time, the correlations between parent and teacher ratings for the same child were only modest. So even though parents and teachers seem to have a similar understanding of what tonic and phasic irritability are, they don't always agree on which children, on the levels of these two forms of irritability in a particular child. So that says something, I think, about there being some situational specificity in the expression of tonic and phasic irritability. So here are the concurrent associations in this sample between tonic and phasic irritability with a variety of clinical characteristics. And in each case, we're adjusting for the other form of irritability. So parent-reported tonic irritability, adjusting for phasic irritability, was significantly associated with higher rates of depressive and anxiety disorders, suicidality, and antidepressant medication, and with lower rates of ADHD and a lower likelihood of having been referred to the clinic for rages. On the other hand, parent-reported phasic irritability was associated with higher rates of ADHD, higher rates of oppositional defiant conduct disorder. They were more likely to be referred to the clinic for rages. They had significantly lower rates of depression and anxiety disorders and antidepressant medication. Turning to teacher-reported tonic irritability was also associated with higher rates of depression and suicidality and antidepressant medication and a lower rate of referral for rages, whereas teacher-reported phasic irritability was associated with higher rates of ADHD and referral for rages and significantly lower rates of depression and anxiety disorders and antidepressant medication. However, both parent and teacher-reported tonic and phasic irritability were related to poorer family and peer relationships and to greater behavior problems in school. So impairment seems to be independently associated with both tonic and phasic irritability. But if we're looking more at internalizing and externalizing psychopathology and related kinds of phenomena, internalizing seems to go with parent and teacher reports of tonic irritability and externalizing with parent-teacher reports of phasic irritability. So just to conclude the irritability portion of this talk, irritability in youth is highly transdiagnostic, and it leads to multifinal outcomes through several processes, including pathoplastic moderators and multidimensionality. So self-regulatory systems that respond to threat, error monitoring, and HPA axis functioning appear to influence whether irritability takes a relatively more internalizing, e.g. Flight, versus externalizing, e.g. fight, PAP. And irritability from early childhood to adolescence can also be parsed into correlated but separable tonic and phasic dimensions that uniquely predict internalizing and externalizing outcomes. They may reflect different causal processes, as our data on temperament and parenting suggest, and they may require somewhat different treatments. All right, let me now shift to the second part of the talk, which is about equifinality and heterogeneity. So equifinality refers to multiple pathways to the same outcome or the same disorder. And it's conceptually equivalent to the notion of etiological heterogeneity. And etiological heterogeneity is ubiquitous in psychopathology, where all disorders, insofar as we currently understand them, are complex and multifactorial. And this etiological heterogeneity is arguably the greatest challenge that we have in trying to understand psychopathology. I'll be applying these notions to depressive disorders in youth. Now, depression is one of the most common forms of psychopathology. It's also one of it is the most burdensome of all mental disorders and one of the several most burdensome of physical disorders worldwide, according to the World Health Organization. And it's one of the most clinically and ideologically heterogeneous mental disorders. That is, there's a very high degree of equifinality, and that's illustrated in this very complicated diagram on the slide, which comes from a study that Kenneth Kendler did many years ago, where he traced the pathways of many risk factors to depression. And it's a very complicated network and certainly understates the complexity of depression, nevertheless. Depression often, most commonly, onsets in adolescence and early adulthood, and it is twice as common in women, in females compared to males, which is relevant to to the work that I'm going to discuss. So equifinality raises the possibility that various pathways reflect more homogeneous subgroups. So each pathway may reflect a somewhat distinct subgroup. And identifying such subgroups could reduce the clinical and etiological heterogeneity that plague research on depression and psychopathology in general. And it may facilitate research on etiology and help provide the basis for more effective interventions than what we currently have. There have been attempts to parse depression into more homogeneous subtypes that different etiology that go back to antiquity. And these efforts have unfortunately been largely unsuccessful. But almost all of this work has been based on cross-sectional symptoms or cross-sectional biomarkers assessed at one point in time. And I want to raise the possibility that a longitudinal perspective may be helpful in parsing subtypes. And there's some evidence for at least two course-based subtypes that are accepted enough to be included in the DSM. So one is the distinction in the DSM-5, in the DSM-3, 4, and 5, between more chronic forms of depression. In DSM-5, it's called persistent depressive disorder, or PDD, and less chronic forms of depression, such as non-chronic major depressive disorder. And the DSM also has a distinction between recurrent and non-recurrent major depression, recurrent defined as 2 or more episodes of major depression, and non-recurrent as having only 1 episode of major depression. And there are literatures that are very separate on both of these typologies. But when we put those literatures side by side, they overlap a considerable degree. So compared to both non-chronic and non-recurrent major depression, people with persistent depressive disorder and people with recurrent major depressive disorder are both associated with a greater family history of chronic or recurrent depression, respectively, with greater childhood adversity and maltreatment, more comorbidity, more suicidality, poorer social functioning, higher levels of a variety of depressogenic traits and cognitions. And in addition, there's evidence that persistent depressive disorder exhibits homotypic continuity over time. That is, patients with PDD, if they recover and then relapse, they tend to relapse into a chronic form of depression. But almost all this research on the differences between these subtypes is retrospective. It's unclear if the differences that I've just mentioned actually reflect differences in liabilities to a more chronic and recurrent course, or whether they reflect the action of pathoplastic factors that influence course after onset and sort of prevent recovery or promote recurrence, or whether they reflect reporting biases in people who have had multiple episodes or long-standing episodes of depression. Could be mood state effects, could be an effort to explain why it is that they're suffering the way they are. So that is one problem. We don't know whether the course-based subtypes actually differ prior to the onset of depression. And secondly, these studies rarely include a non-depressed comparison group. So we don't know whether the differences between these depressed subgroups are specific to chronic or recurrent depression, or whether they apply to varying degrees to all forms of depression and are just more severe in people with chronic or recurrent depression. So in order to answer these questions, it's necessary to study a non-depressed sample and then follow the participants long enough to observe a first lifetime onset of depression and to continue observing them to see whether they recover or have a persistent episode, and if they recover, whether they have a recurrence. And such data are extremely scarce. So we looked at this question in the ADEPT study, which we looked at 465 girls who completed the entire 6 years of follow-up, and at study entry had no, and everybody in the sample at study entry had no history of major depression or dysthymia when they entered the study. But over the course of the 6 years, certainly many of them did develop depression. They were assessed 6 times between the ages of 14 and 20 using the KSATs. And we recorded depression course on a month-by-month basis throughout the 6 years of follow-up through the 6 waves of assessment. The baseline, and we drew predictors from the baseline assessment, which included a large battery of self-report inventories, a structured diagnostic interview, the SKID, and a family history interview conducted with a parent about parental psychopathology. We obtained a parent speech sample to assess expressed emotion, in which the parent had to talk in an unstructured fashion about their daughter, and it was scored for a number of things, particularly critical comments. And we obtained academic records from the school systems for just about all of these girls. So before I get to results, we have to talk a little bit about how do we define chronic intermittent depression. So the DSM has definitions of persistent depressive disorder and of recurrent major depression. These definitions are not unreasonable, but they're somewhat arbitrary and they're not based on evidence. So for example, how long should an episode have to be in order to be considered persistent? We really don't have data. The DSM says 1 year for children and adolescents and 2 years for adults, but that's just sort of, from the seat of the pants. That's not based on evidence. How many episodes should be used to define recurrence? In the DSM, it's 2. Many people have argued that that's not enough. It really should be 3 or 4 that should be, define a recurrent depression subtype. And also, nobody has really paid much attention to the question of whether one should consider the length of the interval between episodes. Maybe it makes a difference between somebody having 2 episodes with a period of recovery of only 6 months in between, compared to somebody who has an episode at age 25 and is well until age 72 when they have a second episode. That may not be reflecting the same phenomenon. Also, as I mentioned, chronic and recurrent depression are almost always studied separately, so that long-standing persistent depressions are often counted as a single episode. They often are a single episode, but an episode that may persist for years or even decades. And so that counts as a single episode. And there are cases of highly recurrent depression. People may have 4 or 5 episodes a year for several years in a row, but that gets counted as non-chronic because none of the episodes have lasted 2 years. And the evidence I just briefly touched on earlier, suggesting that PDD and recurrent MDD have similar similar risk factors, that suggests that they actually may be much more similar to one another than PDD is to non-persistent depression and recurrent depression is to non-recurrent depression. So there may be some value in thinking of them as very closely overlapping and related categories. There's also some evidence suggesting that instead of the DSM definitions of PDD and recurrent major depression, a measure of overall course since onset may actually have greater validity. And there are a couple of studies that have reported data suggesting that. So in moving forward in this study, we adopted a provisional definition emphasizing the cumulative duration of depression since onset, regardless of whether it was a single extended episode or multiple shorter episodes. And given that the study spanned the ages of 14 to 20, we adapted the DSM criteria for PDD in youth to give us a frame for that cumulative duration. And so we decided that the cutoff we would use would be at least 12 months of depressive symptoms, not necessarily all in a row, but there had to be a total of 12 months of depressive symptoms cumulatively. So at the 6-year follow-up, I'm sorry, that says 36 months, it should be 72 months, we divided the sample into 3 groups. The first group we called Chronic-Intermittent Depression, or CID, and these were folks who had these were young women who had a cumulative total of at least 12 months meeting symptom criteria for major depression or persistent depressive disorder. Second group we called Time-Limited Depression, or TLD, and these were young women who had experienced major depression or persistent depressive disorder episode that lasted less than 12 months. Actually, by definition, it couldn't have been PDD, therefore, but it was major depression or major depressions, multiple episodes, but a cumulative total of less than 12 months. And then there was a never depressed group of young women who had no history of major depression or persistent depressive disorder through wave 6, which was around age 20, 21. We also then looked at a number of premorbid risk factors that we assessed at baseline before any of these young women had developed a depressive disorder. And we selected 18 clinical and psychosocial risk factors that have been well shown to be associated with the onset or course of depression. And these predictors were assessed using a variety of different means: interviews, self-reports, behavioral tasks, and they included demographic variables, subthreshold depression, comorbid anxiety and behavior disorders, parental psychopathology, parental care through childhood, the quality of the current parent-child relationship, parental critical comments scored from the 5-minute speech sample assessing expressed emotion, peer relationships and peer victimization, academic performance as obtained through school records, and child reports of trait-positive emotionality, neuroticism, rumination, self-criticism, and proneness to self-harm. So let's describe the groups for a second. So there were 60 young women, about 13% of the sample, who met criteria for a chronic intermittent depression. So they spent at least 12 months of the follow-up in meeting criteria for a depressive disorder. There were 90 who met criteria, or 19% of the sample, who met criteria for a time-limited depression, and about 2/3 of the sample did not experience an episode of depressive disorder during the follow-up. Interestingly, the chronic intermittent group averaged 33 months of meeting criteria for MDD or PDD out of a 72-month follow-up period, compared to only 4 months for the time-limited depression group. So 33 versus 4 months. Now, by definition, these groups should differ, but we didn't expect the difference to be quite as pronounced as this. And even though the chronic intermittent group comprised only 40% of the participants with a depressive disorder, they accounted for a full 84% of the total months meeting criteria for a depressive disorder in the sample. So they are bearing a disproportionate burden of time depressed. So then we compared the groups on the 18 premorbid risk factors, and the chronic intermittent group differed from the never depressed group on 16 of the 18 premorbid risk factors, in all cases showing evidence of greater risk. The time-limited depression group differed from the never depressed young women on 9 of the 18 risk factors. So a number of them, but fewer than the chronic intermittent group. And in each instance, the depressed group showed the higher levels of risk factors. Then maybe the most telling comparison, the chronic intermittent group differed from the time-limited depression group on 9 of the 18 risk factors. And in each instance, the chronic intermittent group exhibited greater risk. So there are a number of variables that are differentiating girls who would go on to have a chronic intermittent depression course from those who would go on to have a time-limited depression course. So variables that are there before onset of depression that are predicting the future course of depression. And we can sort these variables roughly into 4 patterns. Upper left-hand corner, that cell are the quantitative or graded differences. So these are instances where the chronic group is higher than the time-limited group, who in turn are higher than the never-depressed group. And the risk factors that fall into that pattern, that show that pattern, are subthreshold depression, positive emotionality, and self-criticism. The upper right column are those risk factors that are specific to chronic intermittent depression. That is, the chronic intermittent depression group is higher than the time-limited depression group, and the time-limited depression group does not differ from the never-depressed group. And the variables that fall into that category are parental care, quality of relationship with parents, quality of relationship with best friend, grade point average, SNAP and SNAP self-harm, and parental critical comments, come closest to that pattern, but they don't entirely fit that pattern. They fall a little bit in between. Bottom left-hand corner are the risk factors that are common across depressive disorders. So the chronic intermittent group is comparable to the time-limited group, and they are both different than the never depressed group. The variables that fall into that pattern are history of anxiety disorder, peer victimization, neuroticism, and rumination. And a history of behavior disorder, parental depression, and parental substance use kind of fit that pattern best, but don't always exactly fit it to a T. Then the final pattern on the lower right hand cell are the factors that don't distinguish between any of the groups, and there's only one of those. That was parental anxiety disorder. So let me just conclude this part of the talk and the talk as a whole. Depressive disorders are the equifinal outcomes of multiple developmental and etiological pathways. And this phenotype, depression, includes subgroups with markedly different longitudinal course patterns. There's a minority of depressed individuals who have prolonged or frequent episodes, but although they're a minority, they account for the vast majority of the burden, at least in terms of time afflicted, of depression. And importantly, there are differences between chronic intermittent depression and time-limited depression that are evident even before the first onset of depression. Some of these risk factors are specific to chronic intermittent depression in that the time-limited depression group doesn't differ from never depressed controls, but other risk factors seem to reflect risk for depression in general, but are evident at higher levels in the chronic intermittent than time-limited depression group. From a research standpoint, distinguishing these groups may advance understanding of etiology and help the development of more effective and more efficient treatments. And from a public health and policy standpoint, at least I believe that research and intervention efforts should really focus on this minority of cases of chronic intermittent depression in whom disease burden is really highly concentrated. So that is about it for my talk. I hope that it's been interesting. I'm sorry that it can't be in person and we can't entertain some discussion and questions. But feel free to contact me if there's anything you would like to discuss. And I appreciate the opportunity for sharing my work and my thoughts with this audience. So thank you.